I'm Dr Anthony Maloof of Eyes and Faces and Corneal and Oculoplastic Surgery here in Sydney, and welcome to this video on Teprotumumab and Graves' disease. Yes, it's a very hard word to say. We'll move on. So Teprotumumab is a monoclonal antibody. These are a wonderful class of drugs that target specific chemicals in the immune pathway, and there are billions and billions of those, but we develop certain chemicals for certain pathways which are effective in certain diseases to trigger an effect. In this case, Teprotumumab is one of a newer generation monoclonal antibodies for thyroid orbital inflammatory disease, most commonly presenting as Graves' disease. So it's pushed by the big drug companies, and they always come and try and find clinicians like myself to say, hey, we've got this new wonder drug, can we get you to use it on your patients? Which means I become a tool of big pharma and I'm selling a product to my patient. So the first question I ask is, tell me about your drug. What's the safety studies? What's the efficacy studies? What are the adverse effects? And I want to cover some of those with you. What I'm going to show you is the information, not from myself, not from the literature, but from the drug company themselves. I asked them to provide it to me, and I went and had a look through it. They came to me and said, will you use our drug? You know, blah, 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 Dr. Maloof, aren't you great? Whatever. I said, fine, tell me about your drug. So here I want to show you the first bit. So often people with Graves' disease get bulgy eyes, and that bulge is caused by different things. What this graph shows you, when you suddenly get it and the eyes puff up, then when you get treated with Teprotumumab over nearly 6 months, that puffiness which causes bulging settles and the eyes go back in by around 3 millimeters. Great, that's acute disease. This shows the top here is acute disease and the bottom is chronic. And what you see is in people that have long-standing disease, we call that chronic, and there's an assumption that means inactivity, there still is an effect. And what that shows you is there's still low-grade inflammation in the long-standing patients, and therefore that can respond to the treatment. Once again, good. The response is not as effective as in the acute disease because there's more inflammation in the acute disease. All wonderful stuff. What I think is very important is to look at this side of adverse reactions, and I'll read through them. So you can, metabolic and nutritional disorders are ranked as very common, nervous system disorders, very common, ear and hearing disorders, very common and balanced, gut disorders, very common, skin and soft tissue disorders, very common, muscle and connective tissue disorders, common, reproductive and breast disorders, although then it says menstrual. Breast is not menstrual, so I don't know what they mean by breast. General disorders are very common. So that's not insignificant. And if you look at some of them, like musculoskeletal, 42%, and hearing, 20%, and the previous drug had much more hearing problems, they're not insignificant. So if I'm going to look at a patient and say, hey, take this drug, you'll be right, and they come back with all these problems, I've created them. I'm not very comfortable with inducing these sorts of side effects when all I want to treat is inflammation in one part of the body. You get side effects in the whole body. That's a little bit tricky to take. The other thing is the safety data. We haven't really looked at the toxicity to the genome or cancer-causing effects, but we do know that teratogenic deformities are noted in monkeys, and basically it can suppress fetal growth. So there's something going on at a genetic level from that. We don't really know much more than that. So it's very hard as a clinician to go and recommend that to a patient. And the way the big companies do that is they usually come and suck up to you, take you to dinner, say you'll be a developer of this product, you'll be a pioneer. And that's all very good for the ego. So you go off on talks and you say, look, I've done these studies and isn't it wonderful? Because no one ever promotes the negative side of what they do. So that's unsaid, but that's the way it works. I find that a very difficult thing to do. Also, because I've been using something else that limits all those side effects. In fact, it doesn't cause any of them at all. I prefer to give a local treatment just to the area around the eyes with no side effects to the body. Now, up until these newer drugs, we've been using steroids. So some of you who've had Graves' disease will have been pumped through steroids into your vein or tablets. And often you say, patients try and say it was a little bit better, but it didn't stop it. Steroids work, they're life-saving medications, but in the long term, they'll rot you from the inside, rot your bones, give you all sorts of problems, hip fractures, everything. I don't like steroids. So what can I do? I use something called orbital radiotherapy. Now, we associate radiotherapy with cancer, but that's not true. Radiotherapy targets cells and will kill off cells. In this case, radiotherapy will kill off the inflammatory cells around the eyes. So if you can selectively kill them off, you stop the disease process. And that's what I do. Orbital radiotherapy is not about correcting the structural problems such as double vision or a bulge, because they are the effect of the inflammation. It's about addressing the cause of the inflammation. If you can stop the inflammation, you stop it getting worse. Once you stop it getting worse, then you can go back and fix any problems it's caused. If you get it early, you don't have those problems. If you get it late, then you've got to go back and surgically fix the problems that the inflammation has caused, the double vision, the structural bulge. The analogy I give my patients is very simple. If you're sliding down a cliff and you want me to save you, the first thing I have to do is stop you sliding down. Once I stop you sliding down, then I can get you back up. So what all these anti-inflammatory modulators are doing is stopping the inflammation to stop you getting worse. Teprotumumab and orbital radiotherapy, same thing. Why I choose orbital radiotherapy is it limits side effects systemically. In fact, there are none. So what I do is something called low-dose orbital radiotherapy. We use between 8 and 9 grays. The published data show 20 grays with no side effects. Radiotherapy is a dose-dependent side effects. The more radiotherapy you receive, the higher your side effects. So we keep it really low, and the monocytes that trigger this disease process are exquisitely sensitive, so we can use tiny doses. Plus, we use stereotactic fractionated radiotherapy to deliver just the right amount in the right place in a certain volume. And that's called VMAT, volumetric modulated arc therapy. And this is what it looks like. So when you see a scan, if you look at the top left, you see the green. It's targeting just the orbital tissues. You can see the eye is protected, but it's just targeting where the inflammatory disease process occurs and nothing else. So you don't get side effects systemically. It's exquisitely safe. There's no documented causes of vision loss, associations of vision loss. I've never seen it, and I find it really safe and effective. It's also painless. So when patients come to me with this, I generally say to them, well, I always say to them, look, we need to stabilize your disease process. I'm going to recommend orbital radiotherapy. It stops things getting worse. Patients generally find that by 6 weeks, they feel the difference. The ache is settled, the puffiness is settling, the watering is settling. They feel better. That's great, but it may not mean that they look better. The bulge may not reverse, the double vision may not reverse, but I've stopped them getting worse. I generally see them no earlier than 3 months after radiotherapy, and sometimes even longer, or I might see them up to 6 months to make sure it is stable. Once I know the radiotherapy's worked, then it doesn't matter about the immune disease in the rest of the body if I'm going to fix their eyes. Now, managing the immune disease in the rest of the body is a medical problem. There may be other drivers in it. You can have coexistent immune diseases. So I'm not saying forget about it. I'm saying it doesn't target here. What I've done is built, think of a biological fence around the eye sockets. So now the eyes are protected. Once that's done and the orbit is stable, then I can consider stereotactic orbital decompression to push the eyes back in, or we can do squint surgery to straighten the eyes, or lid surgery to fix up all the side effects, depending on what your presentation is. Some people are very marked, some people are asymmetrical, and some people are mild. Everyone needs something different. So I hope that all makes sense. A very complicated name, Teprotumumab, but that's where we're at the current time, early 2026. I'm Dr Anthony Maloof of Eyes and Faces and Corneal Oculoplastic Surgery in Sydney, and thanks for watching.